I will stop there. Let me stop sharing. And will go to the chat to look for questions and then certainly open it up to others who have questions. Okay, so the first question was, is the data on repeat child maltreatment for reports to DCF that were for incidents of IPV? So those were any type of maltreatment that it could have included IPV, but it was any maltreatment. I have a case right now where the father would benefit greatly with the program. How can I get him involved? Yes. So I put the phone number. I also have a referral form that I will paste into the chat too, that people can use. Other questions?
I have a question. I have a case in which the father was referred by DCF, but there was such a long waiting list to get into the program, and it's been several months.
Yeah.
Unfortunately, is there any response you have to that, or what he can do?
Do you know where he was referred?
It's through DCF and in New Haven.
Oh, in New Haven.
Yeah.
So do you know if he was referred to Yale or if he was referred to family-centered services?
I don't know that, but I can find out.
Because if it's referred to Yale, you can email me and I'll check on what's going on with it.
Okay, good.
But if it's family-centered services, I have less control over that. And I know they had some staffing turnover there, but they are up to full staff now. So I would think they would be picking up their pace in terms of getting cases started.
And is your email available, Carla?
Yeah.
Yeah.
I'll put it in the chat. Looking for the referral form here. Are there other questions?
I had a question. I was just curious that I was kind of struck by the bias that you indicated still exists toward thinking that group therapy would be more effective than individual. Do you think that comes just from like thinking it's more efficient and more cost effective, and it works for men who are maybe incarcerated, or not works for them, but like that it's easier? Could you say more about that bias?
It's interesting. I can tell you my opinion about where I think it's coming from. I don't have data on this, but I'll tell you just from lots of times of, lots of years of talking about this. I think there's a couple of things that happened. I think that, the Duluth model was developed as part of a coordinated community response, right? So it was like this whole, the whole plan with it wasn't just a batterers group. It was like, yes, the fathers had to go to a group, but there was coordination between the domestic violence advocates and the courts and the police. And there's a whole like system in place to try to protect women. And it was a valiant, I think, first effort of like, how do we address domestic violence? Valiant effort. But I think what ended up happening is then these guidelines came out in connection with how this program was delivered, this Duluth model group, and it perforated, right, nationally. And now there's all of these providers of these groups. And so I think and I do think that individual providers of the group, they do see change in individual participants. It's not that that they do nothing for anyone, right? The problem is that it's just one size fits all. Everybody shows up, everybody gets the same thing. And so when you have providers who are like, oh yes, I definitely see change, in these folks, and they believe in the work they're doing, because nobody does work they don't believe in, right? So then it becomes this dynamic of, let's say me coming in and saying, oh, I think individual treatment works better. And then people get defensive because it's their work, their life's work, and their livelihood, right? If I say, well, these groups don't work, and then the state doesn't fund them anymore. But there is the other piece of group treatment is much cheaper. But it's only cheaper if it works, right? If people go through it and it doesn't help, and then they have to come back again and again and again, you might as well have delivered the individual treatment, because maybe they would have gotten better the first time. I don't know.
Professor Stover, yes. Carla, Josiah, just thanking you for your presentation. And I have a question about variation you've seen across states you've worked with in how different states approach these kinds of issues, the more punitive versus the more preventative way, any innovations? It sounds like Connecticut is ahead of some other states in some respects here. So how would you characterize what you've seen across the country?
So, So I'd say Connecticut is ahead of the game, and the Connecticut is ahead of the game in terms of child protection. So I still think there are issues related to the courts in that. So when I started this work, actually, I had really great relationships with folks within the Court Support Services Division and like family relations offices. And so the family relations counselors would do assessments. And if they thought a case was a good fit for Fathers for Change, they'd call me up and say, I have this case, what do you think? And I'd say, sure, send it over. We'd do assessment. And there were some cases where I actually think we really potentially saved lives because we did a thorough assessment with people who were quite dangerous rather than just going ahead and sending them to a group treatment where they might sit through it and not raise alarm bells. And there's been a shift in recent years where now, the state through CSSD is funding these contracted services for these 3 levels of groups that they have. And I've been in touch with family relations more recently over the last few years, and they're like, we're not making any referrals to programs other than the CSSD program. So they really are not making any outside referrals at all, which I think is a shame because I feel like the other way they were doing it was better, because I'm not suggesting every case should come to me, to Fathers for Change, but I think there are some cases they could easily identify that either the father would prefer an individualized approach. Some people just don't like groups and they're not going to share in a group and they're not going to benefit because they don't like being in a group. And then there are other people that do benefit from groups, that the other men and the dynamics and having other people call them out in a group works well for them and they, it's helpful. So I think that so Connecticut is ahead of the game in terms of the child protection side, that they really are referring to this kind of program. I think we're still working on it. We have been able to get identified as a Connecticut domestic violence offender program, so we are on the approved list. We just aren't getting, so if someone gets to us, we can show that that's true, but oftentimes they aren't getting to us through the courts. In other states, I'm running up against the same kind of thing where the state statutes around what is considered a domestic violence program, which oftentimes it has to be delivered in a group, makes us not fit the qualifications for those that are arrested. Doesn't mean that other programs can't, that other people can't offer it, but if people have to do a program because they were arrested, oftentimes Fathers for Change would not count in those states where the statute says it has to be delivered in a group. And sometimes it even says it has to be based on the Duluth model, that power and control approach. So there are some states, so Florida is one of them where there's Palm Beach County is trying to do a pilot. We're running up against some of these things where, a little bit of conflict with the BIP, the batter intervention mandates there, and trying to sort of sort that out, that I don't feel like it has to be an either or, that both programs could be of use to the community, and just thinking about who would benefit from which ones. So Florida, and then Kansas City in Missouri is actually doing a pilot program connected. So there's a judge there, her name is Courtney Watchell, and she is really excited about this program. And so she got some funding to do a pilot where they're going to mandate clients from their domestic violence court to Fathers for Change. So we're just starting that. I've trained the clinicians and they're just starting to get referrals now. So we'll see how that works out. But and then I've got some individual therapists who sought out training. Most of them are in California, but they are trying to bring the intervention to, I think, through attorneys and like divorce and family court, through, cases that are up for mediation and things like that, trying to have Fathers for Change be the intervention that's offered for families in those sort of high conflict divorce situations. So we'll see how that goes.
So, Josiah, I just wanted to jump in on that. So, hi. Josover. So I'm a former DCF, a longtime DCF employee, administrator, retired. And I had some thoughts, Josiah, on your question, just in terms of Connecticut's sort of advanced state, if you will, in comparison to other child welfare jurisdictions. I do think that at least, I know you're talking about CSSD and the courts and all that, but I do think that DCF over the last, several years now, really changed their approach to working with fathers in general. And so I do think because fathers, this sort of push to engage fathers in the child welfare, practice and in cases has kind of sort of catapulted Connecticut ahead of the game when thinking about how fathers who, where IPV is involved, how they're treated, how they're engaged, how they are made a part of the case. And I'm struck by something you said earlier about fathers not previously being held accountable. And, I will confess, having worked there for so many years, that was in fact true. And I think the reason for that was because the intervention was easier when you were just focused on the mother. When you have to focus on mom and dad, well, now you've got to engage. You've got to engage both parents in case planning. And so, I do feel proud to say that the agency, under, I'd say, the last maybe 10 or 15 years when I was there, the push to engage fathers. I think Connecticut is really well beyond many other states and jurisdictions, at least in my experience. And I did want to also just make one.
I agree fully, by the way.
Okay.
Everything you're saying.
Thank you.
Yes.
And I did want to say something about the model, which I really love, and that's the restorative portion, which, a lot of treatment models don't they don't include the restorative work. And I know that that's been successful in some other evidence-based substance abuse models that the department works with. And so I do think that that's, I don't know, personally, I just found that that's really a fantastic piece of work when it's included. And then I did also have this other thought when you were talking at the end about the different studies that you're doing in comparison, and in particular, Fathers for Change in comparison to individual drug treatment programs or drug counseling. And I wondered if you were at all had given any thought, because I do know that this happens out there too, of developing or trying to test out a model of Fathers for Change with an individual drug treatment component, like putting those two, putting those two together, because it's so often co-occurring. And I know that there are other models out there that have combined child maltreatment, counseling with drug treatment. And it was just a thought that I had as you were walking through the last part of the presentation.
Right. So the current study, we're comparing Fathers for Change to individual drug counseling, and most of the men are attached to some other, kind of groups or things like that for their substance use in both of those conditions. But previously, I did a study when I was living in Florida in a residential substance use program, and we put Fathers for Change. So it was a milieu treatment setting based on, 12-step facilitation kinds of stuff. And dads that got Fathers for Change, they either got Fathers for Change or they got, an individual focused, like parenting counseling kind of thing. Because all of the men really wanted something parenting focused in the substance. They were like, please, we really want parenting treatment. So we offered that, and Fathers for Change. So in the context of men getting residential substance use treatment and Fathers for Change, those dads were less likely to relapse than the ones that just got the residential treatment and the like parenting support. So I think that the focus on the regulation, and I agree, like with substance use, having more than one meeting, more than one chance to connect with your therapist or your counselor during the week is helpful. So I think it's a good, I think it works well in conjunction with other program. Yeah.
What I was thinking about was, and I'm sure you're familiar because it comes out of Yale, is family-based recovery.
Yeah.
Right.
Mm-hmm.
And so I don't know, the thought just popped into my head as you were talking about that. Wouldn't that be a cool model, right? Fathers for Change and individual substance abuse treatment. Just a thought.
Yeah, thank you. I like that. Thank you.
Dr. Stover, if the pilot programs, either in Kansas City or Palm Beach or both, are successful, do you see any avenue to upscale this type of program, kind of integrating with the court system to have them order this more often?
Well, I hope so. I hope that the data from these trials as well as these pilot initiatives will give us some more, evidence to bring forward. It's really interesting to me, like how difficult it's been to change people's, well, I say that, but I don't know if it's like the powerful people that we can't change their minds, because I feel like I talk to people all the time, all over the country, who are like, yes, it makes perfect sense to do this differently. It's not working, right? And but somehow there's like this dug in
do you think it's
inability to shift.
Do you think a lot of it has to do with cost?
I do think cost is a part of it. So one of the things that we're seeing in the Palm Beach pilot, so this is again where we're singing Connecticut DCF's praises, right? Like they are funding these programs to be provided free of charge to families. So the Palm Beach initiative, right? The dads either have to have insurance or they have to pay. And so there is a little bit of, for families that don't, and in Florida, like people not having insurance is a big issue, so there is a little there. That's one of the things we were just talking about on the consultation call recently, was how are people going to pay for this, or how do people get it, even if they're appropriate? How do they access it? And I'm not sure yet about the Kansas City, how they're planning. I think they have some funding so that they will be getting it free. Like the clinicians are being paid by the court and not by the client.
Thank you. Yeah,
I do think the good thing about Fathers for Change is it is a insurance billable program because it's a clinical therapy. So if people have insurance, they can, they should be able to access it. So that is the benefit. Whereas a batter intervention program is not a clinical therapy, so it's not billable by insurance, but it is cheaper to deliver. So
right. Thank you.
Yeah.
Other questions? Well, Professor Stover, I have a comment and then I have a question. One is to follow on Chris Tanasi's comments as a kind of a pitch for another such session in which Chris was involved with Judge Erica Tyndall and Tawana Brown. Oh, you know Erica Tyndall, Judge Tyndall. Okay.
Yeah.
So she, back in October, did a joint session that is also on our YouTube channel with a young woman named Tawana Brown, and Chris participated in that as well. And I think a few of you others who are here with us today tuned in for that. So I would recommend that folks find that on our YouTube channel. And then my question was, you alluded in your presentation to that it was required that any participating fathers have sufficient English skills that they could, understand the materials. Are you exploring doing a version of this in Spanish as well?
Yeah, so we actually, the DCF locations all have, not all, most have Spanish speaking clinicians. So, and we do have our materials translated into Spanish and some modifications for Spanish families. And then in the trial in our New Haven location, we have Spanish speaking therapists here. So we now have been able to open up the trial to Spanish speaking participants as well. So we're excited about that. I've been trying for a while. It's hard to find Spanish speaking providers.
Thank you. Anyone else? Well, it appears we're going to be able to adjourn a few minutes early. Thank you very much for this really informative presentation and discussion. And thank you, all of our volunteer advocates, for tuning in. Again, this will be available on our YouTube channel with various other materials, and we have some additional videos that are simply available internally. So ask Valerie, Julie, and other colleagues, including now Chris Tanasi, who's joined our team as well, if you need access to those. So again, Professor Stover, thank you so much. And I'm sure there will be follow-up questions too.
Great. Thank you. Good to meet everyone. Thanks for being here.
Thank you so much.
Thank you so much.
Thank you.
Bye.
Bye, everyone. Thank you.
Bye. Thank you.